Okay, so this afternoon we're going to talk a bit more about nutrition and infection and the relationship between the two. But I wanted to start off by taking a bit of a historical perspective again. And start off by showing this data here. So you've got the population of England and Wales showing the, this side is births, and this side in grey is deaths. And these are the age groups. So these are the number of deaths, number of births and number of deaths per whatever it is, 100,000 population or something. So that's 1891, and here is 1966. So less than 100 years. And you can see that in 1891, the median age of death was 31, whereas less than 100 years later, median age of death is up here. So if you ask people, you know, what has caused this massive change in life expectancy? Most people would answer, or I think many people would answer, and especially an audience of doctors would answer, medical science, medicine. It's our improvements in drugs and vaccines and all the things that we have available for medicine. Well, I think you then have to look at what was happening in medical science during this period. So here, if we just take the example of TB, this is a really good example of, here you've got time, and this is the mortality rate from TB. So if we start from 1838, here, mortality is up here. Before we even knew what caused TB, mortality is massively declining. And it continues to steeply decline before there is any kind of drug therapy for TB. So this is when streptomycin was first discovered and used for TB, and this is BCG. So all of this was pretty much nothing to do with medicine. So what do we think actually caused this decline? What do you think? Hygiene, yeah. Can you expand a bit more on hygiene, in particular to TB?
People understood the relation between being clean and washing everything and disease. And they maybe understood that there is a relation between dirty things.
Increasingly, but probably the average person on the street didn't really know very much about hygiene per se in infection, and now I should remember when Koch's germ theory was first published, and I can't, but I'm pretty sure it's around here, I think, but I could be wrong. But hygiene, but general standard of living. So if we think about TB, one thing you might know about TB is that living in close confined space is a big risk factor. But this is during the Industrial Revolution in the UK. So do you think people are going to be living in better conditions during this period in terms of housing density and quality of housing? Actually, no. Because during this period you had massive increase in urbanization, slums, everybody living together in very close, pretty horrible housing that was UK's cold and damp, and everyone's living together. Whereas traditionally, people would have been living in more rural areas with much more air, much less indoor air pollution, because people would have been cooking in less crowded spaces or outdoors. So during this time, you've also got much increased crowding and poor housing conditions and increased air pollution, both outside and inside the home, which we know are TB risk factors. So that doesn't really explain it. So then what else might have improved? Nutrition. So this was a book that was written some time ago by Thomas McCown, which is quite famous, and he made this. He was one of the first people to make this argument that a lot of the improvements in life expectancy were really due to nutrition. And this is from his book, this figure. There's been a reanalysis of his original this book and the data that he used, and it's been slightly his emphasis on nutrition has been dampened a little bit, and that yes, perhaps hygiene and some of the general sanitation and an awareness that TB was contagious, and so they were separating out TB patients, were put in sanatoriums and things like that, but also sterile milk, because a lot of TB was probably being caused by bovine TB. So the provision of cleaner milk, but also just the provision of milk itself, into cities. And nutrition was definitely improving in this period. So the social side of things, it has a big impact, and nutrition is a big determinant of that. So this is just a little bit more detail on that previous figure, showing again that this is CLO, I mean cod liver oil. Does everyone know what cod liver oil is? Did any of your mothers used to make you have cod liver oil when you were little? You're lucky. Mine did. It's disgusting. So it's fish liver oil, and it's extremely rich in vitamin D. It tastes horrid, but it is really good for you. And people somehow, they'd worked out that cod liver oil was good for children, good for people, and potentially helped in TB. So we'll talk more about that in a minute. So that was happening even before we knew about fat-soluble vitamins, and before we knew about vitamin A as an anti-infective vitamin, and then we've got chemotherapy. So you can see that our nutrition knowledge was increasing in this period here. So here we've got cause of death globally. This is analysis, I guess it's a little bit old now, but it hasn't changed much, unfortunately. So here the size of the circle is related to the total number of under 5 deaths. And then you've got the different colours, different things. So from infections, green here is pneumonia, diarrhea, malaria, measles, which is vaccine preventable, HIV, and then here is neonatal causes. And then you've got a bit of injuries and others. So you can see infection is at least half, if more than half, at least in sub-Saharan Africa, with similar patterns in other places. And then I just want to go back a bit to this figure. So the other thing that happened during this period in history, at least in Europe, was that the people that were really benefiting at this time were after infancy, kind of from 2 to 5 years to older ages. So the mortality was still quite large in that very early, neonatal and early infancy mortality was still large, but it decreased so much later on. Okay, and that's a pattern that we're still seeing a bit, in that if we looked at this data now, this yellow bit is the neonatal causes. These are going down slightly as contributions, but the yellow is a bit harder to intervene because that's the early neonatal deaths associated with problems with delivery, etc. But, so this is 1995, where they did an analysis on the contribution of malnutrition on under 5 mortality. And so here, looked at 53 developing countries and nationally representative data on child weight for age, which is not the ideal, but that was what's most available, indicate that 56% of child deaths were attributable to malnutrition's potentiating effects. So it's not saying that they died of malnutrition, but that malnutrition contributes to the increased risk and severity of infections, and that risk of continued infection. So you've just recovered from one infection, but if you're malnourished, you don't really get the chance to fully recover before you get another infection, and then another infection, each one potentially worse than the one before. And importantly, 83% of these were attributable to mild to moderate. So it's where I said that, you know, there's not some magic cutoff at -2 or -3 Z scores. It's a continuum. And it's a population level indicator. It's not just an individual. If you're -1.8, you're fine. And if you're -2, you're not fine. It's a continuum. And then there's a more recent analysis. So now we've gone from 1995 to 2013, and a similar analysis, and still we estimate that undernutrition in aggregate, including fetal growth restriction, stunting, wasting, and deficiencies of vitamin A and zinc, along with suboptimum breastfeeding, is a cause of 3.1 million deaths, and 45% of all child deaths. So that is data from 2011. So it hadn't changed that much. They've taken a broader analysis of what undernutrition means and how you measure it, but it's still estimated 45% of all deaths. And then I'll just highlight that there's this Lancet series, which was all maternal and child, and there's a whole series of really good papers, including some video intros and things of talks. Oops, what's that next one? So normally I never really talk about breastfeeding and infant feeding because I'm mostly teaching students in public health or nutrition that have done all this elsewhere. But I suddenly thought there might be people in this audience that haven't really covered this kind of topic. So hopefully you're aware that it's WHO, UNICEF, and practically every government follow this policy to strongly recommend exclusive breastfeeding for the first 6 months, and that breast milk should be continued for at least 2 years with suitable complementary feeding. But can you tell me why? Why is this such a strong recommendation?
It increases immunity.
Increases immunity, yes. Why?
Adjustment between breastfeeding milk and child's necessary things for growth.
Yep, so breast milk has got everything in it, and specifically, what things has it got in it that help the immune system? Yeah. Immunoglobulins, otherwise known as antibodies. So remember, antibodies generated by the immune system that stay in the body and remember what these certain infections look like. So the mother will pass those antibodies to the child. Anything else? We can discuss in a, yeah.
For example, some nutrients in breast milk have higher bioavailability than other sources, like for example, iron.
Yes, although that's not the best example in this case. So, yeah, the breast milk is, breast milk is perfectly designed, and it changes throughout the breastfeeding period. So the milk that's produced at the very beginning, as soon as the baby is born, what do we call that? Colostrum. Okay, so that colostrum is completely different formulation to later on. And it's really rich in immunoglobulins. The protein and fat content is different, the balance is different to suit the kidney function of the child. And it contains lots of other things as well that we're going to support the infant gut, because that gut has never seen the outside world before, and suddenly it's got to be exposed to all these new compounds. So it contains these growth hormones and things. Okay, but the other thing, maybe I'll just go to the next slide. Here we go. So we mentioned colostrum. Bioactives, this epidermal growth factor, and this is just one of the growth factors, stimulate maturation of the gut is very important. It contains oligosaccharides, which act like prebiotics, so encouraging the good bacteria, and that's also really important that the infant gut is populated with the right kind of bacteria. So we call that the microbiome, or the gut microbiome. It contains all the antimicrobial peptides, lactoferrin and lysozyme. And actually this lactoferrin works by binding iron and keeping iron away from microbes, which is something we're going to talk about. So in fact, you're right in that what iron is in breast milk is highly bioavailable, but there's actually very little in it, because the baby should be born with sufficient iron that lasts for 6 months. That's the idea. Because microbes need and like iron, and it's very important that the iron is kept away from the microbes. So breast milk actually has low iron. But yes, so these antibodies, which also this secretory IgA, which coats the intestinal mucosa and stops bacteria from crossing across the gut. Also white blood cells. And these are things that all act in a kind of innate way to protect the child from the bacteria, from viruses, etc., which are going to be the same ones that the mother's exposed to. And also without producing high fever, which could be dangerous to young children. So we know that, when children do get acutely unwell, one of the worst things that happens is if they get high fever and then they get seizures. So these things are designed to try and potentiate their immune system, which is not fully developed, without provoking a huge immune response that causes fever and can cause problems. And then the other big thing that we forget about is that it's sterile and it's free. So as soon as you introduce any kind of feeding that is not breastfeed, even if it's water, it's not sterile anymore. So this is why exclusive, and again, you ask people, do you exclusively breastfeed? Yes. Survey done. Okay, they exclusively breastfeed. So, do you ever give any water? Well, yes. And you're like, that's not exclusive breastfeeding. And there's lots of different cultures have all these different ideas and beliefs. Some even that the colostrum is bad, and that they kind of even milk the colostrum away because it looks weird and thick and yellow and not very nice, but it's so important. And then other ones that you should feed some water or sugar water before, like a pre-lacteal feed, because they're worried that the child needs something immediately, and perhaps the milk doesn't always come down immediately. So again, when people say they exclusively breastfeed, you have to really probe, because so many people are not. And then some other benefits. Improve neurocognitive development. So again, as we said, the breast milk contains everything that the child needs, and that includes essential fatty acids. So we know that DHA, docosahexaenoic acid, is essential for building the neurons, particularly in the brain, that are rapidly increasing at that age up to 2 years of age. And various other growth factors. So you can add extra DHA to formula milk, which is now often done in high-income countries, but it's still not going to be as good as all the other bioactives that we don't even know what they all are or what they do. So breast milk's always going to be best. And then also evidence that bottle-fed children are at increased risk of being overweight and developing diabetes in the future. And as I said, that's partly because bottle-fed children tend to grow much quicker, and quicker growth is not necessarily better growth. They tend to put on more fat. There's also bioactives in the breast milk which are about regulating appetite, satiety, and making those sort of feedback loops that set the child as to how to control their own intake, which are lost potentially with formula and bottle feeding. And there's also important benefits for the mother too. So breastfeeding releases a hormone called oxytocin, which is the same one that's responsible for inducing the childbirth process and carries on during breastfeeding, and it helps to shrink the uterus back to its original shape and stop postpartum bleeding. Also, in high-income countries, can be quite important because it helps promote weight loss back to pre-pregnancy weight, and then reduces the risk of ovarian and breast cancer risk too. So multiple benefits. And then this is just a simple infographic that was used in the Philippines that basically summarizes those main points. So, saves lives, all the nutrients, it's clean and safe, it can be done anywhere, you don't need to carry a whole load of baby bottles and sterilizing equipment with you. Everything they need to grow, breaks the cycle of diarrhea and malnutrition, again because it's sterile. Important increasing evidence about the sort of psychosocial effects of breastfeeding and bonding between mother and child. There's some evidence that it decreases the risk of developing things like attention deficit disorder, hyperactivity, those kind of things. Some evidence. Of course, it helps space pregnancy because the longer you breastfeed, menstruation doesn't return for a while. And of course, it's free and environmentally friendly. So we've talked a little bit about these micronutrients, and I'm going to talk more about them tomorrow. But as we said, vitamin A is the original anti-infective factor. So even before we knew what vitamin A was, it'd been identified that there was something in cod liver oil, for example, which had this important effect. And then we know, we've talked about zinc and stunting, but also there's an association between zinc and diarrhea. And then I'll talk more about iron tomorrow and Thursday. And I talk about it as being this double-edged sword in that we need iron, but so do microbes need iron. So there's this potential battle between us. So just a little bit more vitamin A deficiency and infection. So vitamin A deficiency really became known when it's most extreme and you start to see these eye signs. And that's because vitamin A, which is retinol in its pure form, is needed for the function of the cells in the eye and also for epithelia, and whether that's sort of any particularly mucous surface in the epithelial that's constantly replacing, vitamin A is an important part of that. So the clinical signs, the first sign is actually night blindness, because you need retinol for the rhodopsin in the eye that detects light. But again, that's quite non-specific? How do you objectively measure night blindness? The next one is Bito's spots. And then you get this kind of scarring, which eventually will lead to blindness, and this is called xerophthalmia. And here's where you can see these, that's quite a large Bito's spots, and scarring is beginning here. So vitamin A deficiency used to be the most common cause of blindness in the world. And it was a guy called Alfred Summer who brought attention back to vitamin A, because it kind of got forgotten about for a while. And so in the 80s, I think this was done in Indonesia and India, he did observational studies and looked at the relative risk in children with actual eye signs of deficiency and their risk of getting acute respiratory infections or diarrhea. And you could see that here the relative risk of ARIs was 2.3 in Indonesia, 3.4 for diarrhea, 4 in India. It's a little bit unclear why diarrhea was lower in India. And a similar pattern at older age groups. So that study of Alfred Summer then led on to intervention studies, and in the interest of speed, I haven't shown you all those studies which were being conducted giving supplementation, but it's now accepted that there's really strong evidence that giving vitamin A supplements to children 6 months to 5 years of age reduces mortality when there are populations at risk of deficiency. And this, we think, is probably one of the most effective public health interventions that have been done in recent years, equivalent to insecticide-treated bed nets for malaria. So nearly all governments in low and middle income countries where vitamin A deficiency has been or might be a problem, it's now policy that you give the vitamin A supplements. And because vitamin A has a long-term store in the liver, you can give large doses just every 3 to 4 months or even every 6 months. So compared to many other micronutrients, it's actually relatively easy to tackle programmatically because you only need to supplement 2 to 4 times a year, and that can be done at the same time as other contacts with these children, like during vaccination, for example. So after those first big studies where they treated children with eye signs and showed increased or decreased mortality, they then expanded to supplementing all children. And then from there we see that even children with subclinical deficiency have a greatly increased risk of mortality, and you can see functional deficits in their immune function. Hence why you just supplement the whole population. If you have a population at risk, you just blanket supplement everybody. Just briefly, what foods are rich in vitamin A? So the really rich sources are animal products and liver, because the vitamin A is stored in liver. So that cod liver oil, the fish liver oil, is really rich, but liver from any animal is going to have a rich source. Otherwise, it's really from fruits and vegetables and from the conversion of carotenoids, which include beta-carotene, which is what makes orange vegetables orange, gets converted to retinol. But there are also a whole load of carotenoids in dark green leafy vegetables. However, in the last, I guess it's maybe 10 to 15 years, we now know that the biochemistry is a bit more complicated. That we used to think that 6 molecules or units of beta carotene was equivalent to 1 molecule of retinol. But the biological conversion is actually not nearly as efficient, especially when it's from these different foods. So now we actually think that from orange-fleshed fruits and vegetables, it's more like 12 to 1. And from dark green leafy vegetables, it's more like 24 to 1. So hence, to meet your vitamin A from vegetable sources, you really need quite a lot of those vegetable and fruit sources, which explains why deficiency was still prevalent when we thought, well, they should be getting enough. But that's because we were overestimating this conversion. So a little bit about zinc. So zinc is a mineral and needed in quite small amounts, but zinc is a type 2 nutrient, so there's no store, which means you need to take it in daily, regular small amounts. And there's zinc in all sorts of foods, but the problem is that it's not always very bioavailable. So in cereals, your staples, in whole grains that generally we recommend nowadays for high fibre content and more nutrients, B vitamins especially. But some of them have also contained these high levels of phytates, which can inhibit the zinc availability. And then, as I said, zinc is needed for almost every process. But it's also, again, needed to maintain the epithelia. And when you have diarrhea, what's happening is that you're losing the lining of your gut, and with it you're losing a lot of zinc and, in fact, iron, because it's contained within those cells. And you really need the zinc and the vitamin A for this cell differentiation in the gut, because if you imagine, you're constantly turning over the inside layers of your gut, and so therefore it has quite a high requirement for zinc. And it's also needed for all sorts of immune functions and antioxidant functions. So zinc deficiency, we know, is associated with your immune system not working as well as it should do. And then rich sources would be meat and shellfish in particular. But it really, if you have a diet that's not really limited and it's not really high in phytates, you should get enough zinc. So again, we started with observational studies showing that zinc deficiency was associated with increased risk of respiratory and diarrheal diseases. And so here, different disease conditions. Here's your relative risk for being sick, for morbidity. So here, relative risk of 1.28, so that means a 28% increased risk of becoming sick with diarrhea in children who were zinc deficient compared to those that weren't. 52% for pneumonia, 56% for malaria, and similar. And you can see they're all statistically significant because they don't cross 1. So more evidence was done with trials since then. And now one of the big discoveries and interventions has been that giving zinc during acute and persistent diarrhea decreases the duration, severity, and risk of treatment failure. And this is irrespective of what's causing the diarrhea, irrespective of the zinc status of the child, and it also works within a community setting. So this was a trial, cluster randomized trial, where they added zinc in with oral rehydration solution and gave it to mothers to manage at home, and showed that it improved outcomes. So now most countries have a policy that during diarrhea, including in high-income countries, because it doesn't matter what your zinc status is, to give zinc during diarrhea. And India was one of the first countries to make this a national policy. Okay, we'll talk more about zinc later. And I'm going to skip this because I can talk more about iron later on Thursday. Vitamin D. Just thought I'd talk a little bit about this one because it relates to, again, to TB. And at the moment, in nutrition, as in many other areas of sort of science, public health, things go in trends. Everybody starts getting interested in one thing. And the interest in vitamin D is still, suddenly vitamin D seems to be important for almost every condition you can think of. The reality is, of course, always more complex. But there is evidence that vitamin D, so it's not just about bone health. Vitamin D is acting as a transcription factor and as a hormone for a whole load of processes and is required for immune function. So vitamin D has been associated with schizophrenia and depression, infections, particularly TB and respiratory infections, other kind of lung diseases, autoimmune diseases, cancer, associated with malabsorption. So there's a huge different things. So the only other thing is that if you don't know, you can make vitamin D in your skin from exposure to sunlight. So in a way you would think, well, why would vitamin D deficiency be a problem? Because you don't even need it in your diet, you can make it. But in latitudes that are far north or far south, the wavelength of the light is not the right wavelength to allow you to make it in your skin. So even in the UK in the winter, that wavelength skips off the surface of the earth, so you don't get any. And then in populations who tend to be covered, then they might not be getting any skin exposure. Plus you have populations with dark skins that need more exposure to generate the same amount of vitamin D. And then we now know that there's also quite a lot of polymorphism, genetic variation in vitamin D metabolism, which might underlie some of this and why it's more complicated than it first seems. But this is why I always think it's interesting to take historical perspectives on things. Again, I try to encourage students to remember that to go back to the literature beyond the last 5-10 years. Often people think, oh, there's no point looking, it's old. But there's often things that we knew about that we've then forgotten about and that we were perhaps right in the first place. So before streptomycin, part of what TB treatment used to consist of in Europe was making everybody go outside in the sun because they felt that sunlight and fresh air was good for you. And they were right, because vitamin D is important and you're going to make it. And the fresh air was good because you're in a closed environment, you're just more exposed to the bacteria. And then there was a lot of excitement that vitamin D might really help in improving outcomes in TB. So this was a well-conducted large trial in India. I'll go through it very quickly. So they looked at time to culture conversion. So the first time that you can't culture the bacteria from a sputum, but no difference. And when they looked at all the other outcomes, unfortunately, no difference. So why do we have such good observational evidence, but not good evidence when we intervene? And that's where we need to remember that the biology is often a lot more complicated than we might like to think. We always want to reduce things in a reductionist, simple way. But biology is not like that. So we see lots of associations, but when we intervene, we don't always see the effect that we'd hope for, or sometimes we see the opposite effect. And that's because there's genetic variation. So different people have different requirements. They're going to react in different ways to the intervention, perhaps because there's these polymorphisms in the vitamin D receptors. And it's also about when is it going to have an effect. So vitamin D has, again, a very complicated set of actions. And now the current thinking is that vitamin D might be much more important at controlling risk of TB in the first place. And so a colleague of mine is doing a massive trial in Mongolia, where, of course, there's limited vitamin D, limited sun exposure, so lots of vitamin D deficiency. And she's randomized, I think it's 11,000 children to vitamin D, or not vitamin D, excluded that they've got TB already, or they're not infected, so they haven't got latent infection. And then randomizing them to look at the risk of developing first in ever infection. And I'm hoping that that trial is going to have a positive outcome. And then you have to remember that animal models are not always good models to look at. So I'm going to skip on a bit. So now the practical. We've talked a lot about this cycle between nutrition or undernutrition and infection and disease. But I want you to think a bit more about, well, what are these processes? How are these things happening? And to consider the special cases of low birth weight infants, and perhaps the elderly. But some of you might have specific interests in these groups of patients. Maybe what about HIV patients, or considering just general children under 5, TB patients, refugees. So in your same groups, I want you to start thinking about what are the processes, what do we know about what happens during infection that might increase your risk of malnutrition? And then what do we know about undernutrition that might increase your risk of infection? I've got a slide that I'll put up after a few minutes that will prompt you a bit more, but I want you to think a bit first before I just put the answers up. Okay, so same groups as before, and then we will come round and talk it through with you. So I think pretty much everyone came to these things by themselves or with chatting with myself or Aiko-san. So, I said I like to think of it as like this, potentially. In a high income, good, clean environment, then normal, healthy children get sick, that's normal, but they have time to recover and recover their nutritional status before they're hit with another infection. But the mechanisms involved are really that, particularly systemic infections, then you have fever, and for every 1 degree increase in body temperature, the basal metabolic rate increases by 13%. So if you think the normal temperature is 37.4 degrees, if you've got a fever of 40 degrees, your metabolic demands have gone up massively just in terms of energy. And then another sort of extra detail is during that fever and inflammation, you make acute phase proteins, one of which is called CRP, or C-reactive protein. And that has a high concentration of one of the essential amino acids, cysteine, that contains sulfur. So to get enough of that cysteine, you then need to intake extra protein to get enough of that single limiting amino acid. So your whole amino acid protein metabolism is altered and not as efficient. So you have increased demands from fever, increased protein requirements. You may also have this metabolic disruption where you might have these cachexic processes where your metabolism is all directed towards breaking down rather than building up. And it's a similar process to cancer. So in cancer, you get cancer cachexia. And one of the early signs of having cancer can be an unexplained weight loss. And it's actually a very similar process in these kind of infections. And then, of course, associated with being sick is you might have reduced appetite. So if young children often don't want to eat because there's no appetite, they might find it difficult to eat because they might have sores in their mouth or a very sore throat, which make it difficult to eat as well. So you've got increased expenditure and decreased intakes and decreased efficiency. And then you're also, if these diarrheal type diseases, you're going to lose nutrients through the diarrhea and not be able to absorb nutrients as well. So the illness can increase requirements, increase losses, decrease intake, and decrease efficiency. So they're all ways that can lead to undernutrition. And in a good, healthy sort of environment with access to good food, once the child begins to recover, then they will start to eat, and they will eat more afterwards, and they will just recover back to where they were. But if those foods are not easily available, or they're being hit by infections all the time, they might get the next infection before they've had time to recover. Then the undernutrition, as we talked about, leads to reduced immune functions. And really, probably the most important one is this innate immune function and the barrier effects of the skin and the epithelial. The immune system is actually quite robust. So you'll see some other slides that we didn't have too much time to go through, which summarizes what functions are affected by malnutrition and which aren't. But the antibody system is actually pretty robust, because those antibodies are there, should be there, sitting there ready to go. They don't really need specific energy. So the kind of immune system is robust, but it's really this barrier function that's most affected. And it's also this barrier that then causes an increased pathogen load. So we're all being hit by potential infections all the time, but maybe the dose that we get is pretty small because our barriers are working well, so we're blocking 90%, let's say, a few gets through. But if your barrier is not working very well, maybe 50% get through, so you get a much bigger dose. So you get increased pathogen load and therefore increased severity of infection. And also you can get this increased risk of co-infection. So lots of infections, like for example malaria, you might get bacterial co-infection on top of the malaria, which becomes more likely if you're malnourished. And then again, for your immune system, when it's working, it requires more energy, and particularly protein. So it's also increasing your demands from the immune processes as well as from the fever. So I've given you a handout which talks a little bit more about the specific cases of low birth weight and the difference between premature and intrauterine growth restricted. The important point is that actually the children who are intrauterine growth restricted have bigger and longer term impacts on their immune system than the premature babies generally. And then there's issues around ability to feed and to suckle, particularly for low birth weight. Elderly, there's a lot of issues around sort of social conditions, drug interactions as well, loss of appetite. Your immune system starts to not work as well as you get older. And also things like, and this is one that I don't think any time I've done this, any student has ever voluntarily suggested it, but dentition is really important. And in low-income countries, generally, people don't have good access to dentists, and they often can't chew their food or eat their food properly. So that's just a few of the special examples. So for those that are interested, there's a good review. That's just summarising the different things that are affected and unaffected. You will also be sent electronic copies of some different documents which are available to you if you are interested, so sort of extra resources. So some of them are targeted more at if you are clinical, and some more if you're interested in sort of community nutrition. For the clinicians, there's a really good paper written by a colleague of mine which is about how you manage infection in severely acute malnourished children. So if any of you are ever working on wards and they're coming your general ward, then how do you manage TB or how do you manage diarrhea in acutely malnourished children, bacterial infections? It's a really good summary. And then if you're interested and you haven't really done much immunology, that little tutorial I think is very good, and there's a list of other little tutorials as well. Okay. So thank you very much for today. Thank you for joining in and being active, and I'll see you tomorrow.